the external supply chain market is moving so fast. Prices, volatility, supply availability is just speeding up. So even if you make a good decision today, it may not be a good decision tomorrow. And so staying on top of all that is really the biggest barrier we've seen to hospitals being able to do as well as they could do.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On this episode of Power Supply, we speak with Matt Hebbard, VP and co-founder at QuicksortRx, and Johnathan Yantis, CEO and co-founder at QuicksortRx. And Gary, we're going to be talking about, surprisingly, for the very first time, pharmacy supply chain. We're going to get a baseline understanding of how new pharmacy supply chain leadership and staff get into the business. We're going to talk about what resources they have available to them from a technological perspective, and then what can be achieved in the big picture as we start to build out those resources and that experience and training.
Justin, I'm really curious to see where this conversation goes. I think about it from a supply perspective. Pharmaceuticals, top of spend, big time spend, and completely specialized. You need the SMEs, you need the subject matter experts to really help out with this. This is a big deal. I'm really curious to see, as you said, you did say it was our first one in pharmaceuticals, correct? Pharmacy?
Yeah, I think the only other conversation I recall is when we were talking about the chain of custody, when we did the third party logistics conversation very early on, one of our very first episodes, and talking about chain of custody during the pandemic and how the lack of, human to human interaction really disrupted that. But outside of that, I don't think we've had any focused pharmacy conversations.
I think it's a great fit. I'm really looking forward to see how it plays into our power supply conversations. Good to have them here today. So looking forward to it.
All right, stay with us. We'll be back. Johnathan, Matt, up next.
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
A production of 17 Studios. You're listening to Power Supply.
Joining us now is Johnathan Yantis, CEO and co-founder, along with Matt Hebbard, VP and co-founder at QuicksortRx. And we're going to be talking about pharmacy supply chain today. And the two of you are quite a tandem because you have a technology background and you have the pharmacy background. And we're going to relate all of that to supply chain and improvements that can be made as we talk through this today. So Johnathan, we'll start with you. Thanks so much for coming on the show. Why don't you tell us a little bit about yourself?
Well, thanks, Justin. Thanks, guys. I'm excited to be here. So, my background's in computer science. I spent most of my career after graduating at the Medical University of South Carolina. And so I worked in the IT department. I was our network architect for many years, worked with our genomics department, radiology, loved complicated problems. And so kind of along the way, I got the chance to run an innovation team and was told to go out and find some big problems in the hospital where I could make a difference outside of just technology stuff. And that's where I met my co-founder here, Matt Hebbard, who was working in supply chain. I'll kick it off to him.
Hey, so I graduated from the University of Georgia College of Pharmacy, which I know is controversial these days with Hays.
Oh, that's tough to hear.
But when I graduated, I didn't have a lot of direction. I knew I wanted to move to Charleston. That's where my wife was moving and for her residency. And so I ended up getting a job at a small community hospital out in Walterboro. It was about 80 beds. There were only 4 pharmacists there. And so we had to cover a full hospital, and we were there about 12 hours a day and then on call at night. So you learn to wear a lot of hats, right? So I was, partial IT pharmacist, partial doing controlled substance audits and doing all this other work, operations, automation. I stood up a Pyxis system there. Joined MUSC in 2012 to help build out Epic. And so MUSC was moving their oncology department from paper to the EHR. And I got to be a big part of that. And from there, they moved that group after a couple of years under the IT umbrella. I stayed under pharmacy with high risk and high cost projects with, medication stewardship and some other stuff like that. And so I got into supply chain looking for a high cost problem to solve. I tried to do it myself. I did some spreadsheets. I wrote a little bit of software that ended up being not very good. I came to ask, really, really not very good. I came to ask Johnathan a question or two, and he, I guess, took pity on my coding skills and jumped in to help me out a lot. And so that's really how we ended up getting together.
Well, it's a perfect match if you think of it, honestly. And so, unfortunately, you couldn't get in University of Tennessee Pharmacy School, so you had to go to Georgia, but that's okay. But give me a sense, because I think generally our listeners that are with us here, they understand supply chain, they understand pharmacy to an extent. But generally, what is the budget of pharmacy as it relates to supply spend? And just kind of give me a overall, how big a spend is it? Do you have a good feel for that?
Yeah. So materials and pharmacy have a pretty similar budget size, or at least they used to. That was sort of the benchmark before. I think with oncology spend and specialty drugs, that's starting to get outweighed a little bit on the pharmacy side. Typically, under labor, the next biggest cost is pharmacy. And so for a 700, 800 bed hospital, you're talking $40, $50, $60 million a year just on inpatient medications, probably 100 or 150 on infusion if they have their own infusion sites. And that's even after, 340B discounts and stuff like that. So it's a pretty big chunk.
Huge chunk. Yeah, absolutely.
So how is it different? I mean, we've done so many episodes on what I don't want to say traditional supply chain, but a lot of times when I go to, different conferences, there's like a pharmacy track and then there's a healthcare supply chain track, right? And so I'm assuming that there are definitely some similarities just to some degree in the contracting realm and whatnot. But what are some of the differences, Matt, and how do those differences lend themselves to unique needs in terms of why you were writing your own software?
Yeah, that's a great question. So we actually got a great chance to talk to some folks about this summer down in Phoenix. It's been pretty eye-opening to see the gap as we've learned more about traditional supply chain, is I guess what I'll call it, and knowing what we know about pharmacy supply chain. So in a more traditional supply chain, you've got, there's degrees that you can earn and learn about for traditional supply chain training. They're not all out there, but there's a master's program out there at Belmont when we were in Nashville that I saw. I was going to bring that up, right? But
shout out to the great state of Tennessee.
Yeah. But, there's a lot of sort of history in building that up, and a lot of folks see it. They tend to have a pretty big presence, especially after COVID, in the C-suite, right? They tend to have a lot of communication at that level. Pharmacy supply chain tends to be pretty insulated. It tends to be in the pharmacy department mostly. We're starting to see that change. I would say the other big gap is the specialization of knowledge, right? There's a lot to traditional supply chain. Take the widget that you want to use in your hospital, hand it to a bunch of folks, let them try to break it, see if it's durable, if it's useful, and if it's cost effective. In pharmacy, it's a lot of that is more specific, right? Does this have benzyl alcohol in it or not? The wholesaler says they're pretty equivalent. They may even be AB rated, equivalent by the FDA, but there's certain things that we're not going to be able to use in our hospital if we have a peds department or bone marrow transplant, things like that are going to be more specific even than what most of the resources we have out in the world view. Finally, I'd say, traditional supply chain has a lot of self-direction. It's, they're going out to pursue some deals. They may see some things come across their desk and be able to jump on them. Pharmacy's always sort of been a little bit reactive, right? Reacting to a shortage, reacting to a market change.
There's a lot of clinical knowledge required in the pharmacy supply chain, and there isn't this sort of base of contracting knowledge, supply chain knowledge that you see maybe in other areas. It's very clinically focused in our experience. Now, that clinical focus is absolutely critical to the operation of any pharmacy, but they don't seem to benefit from the training programs and the education and other things that Matt said that you find in a traditional supply chain environment. There's less MBAs out there. There's certainly a lot of MBAs in pharmacy supply chain these days, but less so than you would find in a dedicated sort of perioperative supply chain or other, supply chain areas in a hospital. And so that part's coming. So we start to do that more and more.
So that's a kind of a good segue for this question as it relates to the role the GPOs are playing on formula development, on pricing, and on contracting. How impactful or helpful is that for the system? In other words, they're getting these contracts rolled over to them. Do they just roll with them and keep going, or do they normally try to negotiate even better deals off of what's kind of provided for them?
I would say for the most part, they go with, great contracts that are available to them. These days, what you're seeing is because of the 340B regulations and sort of the regulatory constraints within the market, it's more complicated and it sort of transcends just the GPO area these days because they have to focus on what drugs they're going to use in their outpatient setting. They've got to focus on what drugs they use throughout their hospital. They've got multiple prices they have to pay. And so a lot of times if it's just inpatient exclusive, that GPO contract, very effective and a lot of times they can reach for that. But in a lot of other areas, depending on the drugs used and things like that, and they're paying, different prices in different areas, yet from an inventory standpoint, they need to keep one inventory. But it may not make sense. It may not always make sense to go with their GPO contract if it doesn't apply to their entire hospital. So,
Matt and Johnathan, I really like the perspective you're giving on this too, and whether or not you decide to use the GPO or you decide to do an enhanced local agreement or you just, work with the suppliers and the vendors how it is. But the role of like supply chain integration, are you seeing from your guys' experience, are you seeing certain supply chains people integrated underneath the umbrella of like a model where they're underneath like the VP of pharmacy and their supply chain person is put in there? Or is it more of a teamwork collaboration and a handoff to make sure help to support some inventory controls? Or is it a hybrid model? I'm just trying to understand your experience, what you've seen and how they have been involved, because there is a part of that negotiation strategy, sourcing, contract alignment, agreements, all that stuff that comes into play, because I'm thinking about time. And I know I've come a lot full circle here, but I think about time. You guys are trying to take care of patients. You're trying to integrate and move this forward to make sure we got what we need on ICU and the Pyxis machines and out the clinics. What are you seeing as the model, I guess, and is it shaping differently? I guess I'll stop there.
Yeah, I think hybrid is probably the closest what we see from a future-looking perspective. We see it all. BSC recently rolled their pharmacy supply chain under the chief supply chain officer. It's been a lot of learning in that space, right? So I think it's really interesting to see and to talk to chief pharmacy officers even that, they've got their supply chain folks can get a letter of commitment signed. They can, buy stuff. They've got, signatory authority. And then, even the chief pharmacy officer can't they can't get that kind of paperwork pushed through in the same speed. So even just at a supply level, not even a service or technology or anything like that.
And I appreciate that. And I look at the hospital supply chain side. We're only as good as the SME. I always say the SME, the subject matter experts, and trying to understand that. I mean, Johnathan, you talked about that, just understanding it, it's like, it's a whole new world, right? It's a whole new world of integrating the understanding of serotonin, norepinephrine, dopamine, which Hays has a lot of. I mean, he's always so darn happy, and I love just throwing that out.
Oh
He's got satiety, his gut's solid, he gets that every day. And, but I get it. We have to have the schmees. We got to be involved. So I love your hybrid comments. So any other comments, please?
But just before we move on from that, I think there's a lot that supply chain can learn from pharmacy too, right? About the operational impact of some of these decisions. I know that's been a big part of the integration and the part that both sides can take something great from a partnership here, even just a closer network rather than having it be so isolated. But I know the supply chain folks are always really impressed with the pharmacy supply chain perspective on how this is going to roll downhill. What are the impacts and what do the clinicians think of it and how's it going to impact patient care? A little more clear because of their direct line to the pharmacist. They're on the floor. They're hearing from the nurses first when something's broken. They have a lot of perspective there.
And one last thing on that, we're seeing a lot of hospitals want to consolidate, into an ERP system. So at least from a financial standpoint, they want to consolidate all their invoicing and all their purchasing through a central system for the hospital. And so that is also pulling pharmacy closer into supply chains for a lot of these hospitals as they sort of roll out these integrated ERPs across the system. So
They're kind of forced to do it to take advantage of the conversion or the implementation. Yeah, that's excellent. So when that happens, all of a sudden there's a different level of engagement, right? And to integrate into the ERP, it really helps if you have some foundational technology in place already. How ready are most healthcare organizations, by your estimation, to have that foundational technology in place for that integration? Would you say, on a 1 to 10 scale, 1 meaning no technology whatsoever, 10 meaning with the right team, it's a plug and play kind of experience, where would you say the average hospital lands throughout the U.S. in that regard?
Average is tough because I'd put the average right around 5 because we see a lot of zeros and we see a lot of 9s and 10s.
You literally see zeros, that there are people that are just have no technology to even work with, and then all of a sudden they implement an ERP and they're going from the ground up on that. How painful is that?
I assume very painful. But when you think about supply chain and pharmacy, this gap again, right? Pharmacy led a lot of technology implementation for distribution within the hospital, right? And that's still within the 4 walls. We had, the automated dispensing cabinets. We had all those things. But we've been in places that are still using shelf tags to order. They don't have a favorite NDC. They sort of, which is, which drug product you're going to choose today. But they are really just running by the seat of their pants. And then on the other side, we see folks that have, a very mature system. They can control multiple hospitals from one place and guide them to the right decisions, or even, reinforce those decisions. I want Tylenol, it picks the right one and takes it from the right place and puts it in the right spot. So we see both ends of it. I would say the majority are a little farther behind on what technology they've even had made available to them.
So let's say you're a new technology provider and you're coming into this pharmacy supply chain space, and you're kind of knowledgeable of the fact that there are some organizations out there that have no baseline technology to manage this. And knowing that just about everybody is trying to implement ERPs. I mean, that's such a constant and consistent conversation these days. How should an emerging technology approach empowering these hospitals with data, with technology? What are the best practices and focal points? What are the early wins to give them that foundational technology that's going to help them really scale up and put in best business practices that are driven by data?
I think from our perspective, make it lightweight, right? Don't make them have to change everything to adopt a new technology. For us, though, it's really meeting each hospital where they're at. So our goal going in is to assess, what is their maturity? What is their operational maturity, their financial maturity as an organization? And then, hey, where are they today and where could we help take them without causing too much disruption or having them bite off more than they can chew. So it really kind of runs the gamut for us, which is we want to take them from where they are to, a brighter future, at least in supply chain, help them learn what other hospitals are doing. But, if they're scanning shelf tags, that's where we meet them. And then we try to slowly improve things. But a lot of these places are resource constrained, and it just really depends on where they are and what's possible for us to do together to make things better. But we're not going to take them all the way to the end. That's more of an organization. That takes many more people in the organization. So
I'm not asking to name names here, but on some of the really bad ones, are we talking like I mean, like the real small, very rural systems? Are we talking, have you seen some, large systems that are just not very good as well?
Yeah, I want to couch this two ways. One is that even a really bad system is being run by really great pharmacists.
Of course.
And what we see is not like a lack of will, but usually a lack of resource. Right.
I mean, it's normally a money issue. That's the reason I asked this. Yeah.
Right. We're mashing on a spreadsheet for 8 hours a day to try to figure this out. And we're doing what we can with what we're given. But yeah, we've seen 700, 800 bed systems that are scanning shelf tags and, reordering what came in last without a lot of strategy, just because, you've got so much out there to look at. It's such a complicated problem. They either, take all the advice they get at face value, or they just, persist and improve where they happen across them. When Jonathan was talking about meeting people where they are, I think that's really a big gap. We talked a little bit about the educational opportunities available in traditional supply chain. There's not a pathway for pharmacy supply chain that really has been established. It reminds me when I was an IT pharmacist, or an informatics pharmacist is probably a better phrase for it. There didn't used to be one there either, right? You sort of figured it out. You got that job and you got into it and you got better, or you got out. Now there's, training programs. You can do a residency in informatics. You see a lot of admin residents that end up in supply chain, but there's not like a way to learn this stuff. It seems to be so we found being able to find folks, understand them, train them up, get them up to speed, personally, as well as the software side. There's a lot of teaching in this environment. So.
We just did an interview with Derek Gallagher and Rachel Anderson from the Young Professionals Advisory Council with ARM, and we were talking about that, not in the context of pharmacy supply chain, but just supply chain in general. And what is interesting is, I think what you have said, or at least alluded to several times, is that most of the folks that are getting into pharmacy supply chain are pharmacists. They're not necessarily coming with a supply chain background. And so you just brought the informatics component to the table, in that where they're getting the supply chain experience is from informatics, training specifically in informatics, and not necessarily, again, traditional baseline supply chain foundational knowledge. And so if you give them the data with a supply chain perspective in place and they have the informatics, they might know what to do with it, right? But to just build that on their own without a supporting structure to help them think and observe and see that information in a supply chain light, they might still have a blind spot, despite the fact, like you said, some really great pharmacists leading the way. Is that a good summation of where you kind of feel things are at?
Yeah. So, current state, I'll just say, I have one hospital in mind, and I'll say the last 5 people that had the supply chain role. One was an inpatient pharmacist tapped to do supply chain. The next one was an informatics pharmacist who sort of fell into it alongside that person. The next one was a retail person that the informatics guy trained up. And the one after that was a retail pharmacy person that guy trained up. And so the idea of this sort of like, hey, I lost my transplant pharmacist to another hospital. Where can I find a good PGY2 trained transplant pharmacist to jump in here? That it really doesn't exist. And so as these supply chains are getting more mature, they're finding a need for more specialization. They're hiring away these great folks. There's just a gap, and it's very hard to fill without committing some manpower to train these people up.
So from a supply chain perspective, right, with the right information, what are some key areas that we talked about empowerment, right? And how are we empowering with technology? And, I think the data and informatics component of this is really loud and clear, but I don't think we've targeted yet the true end result. This is what can be achieved when you put in these types of structures or technology that can build these structures and take advantage of the talent that you have, but really guide some of the thinking around the supply chain aspects. What are the results of that? What can be achieved? And Johnathan, I heard you loud and clear too, that you shouldn't change a lot of what they're doing. So I hear the technology is just giving, and then you're doing something with that technology and that information that's coming from it. What can they do with that? It seems like it could be a low lift, but that there's a lot of opportunity.
There is a lot of opportunity. I think in the past, in order to make any decision, they couldn't even make the decision on one team. They would have to bring together all this different data and all this knowledge from multiple people, from multiple teams, in order to make a single change in their supply chain, because they might impact some compliance numbers. That might impact their GPO rates. That might impact their cost of goods. That might impact their 340B program. And so there's so many factors that they have to factor in to make a decision, and to go from this might be a good decision to I'm comfortable making this decision requires so much information. And the risk of a mistake can be very expensive. And so for us, our goal is to bring together all that information literally on one screen so that they can see every variable that they may need to care about and what will happen if they make a change. And so they can feel safe about it and move on and then see the results. But also know, the external supply chain market is moving so fast. Prices, volatility, supply availability is just speeding up. So even if you make a good decision today, it may not be a good decision tomorrow. And so staying on top of all that is really the biggest barrier we've seen to hospitals being able to do as well as they could do. Being able to quickly make decisions and then be able to stay on top of things as they change. And they change constantly. So
that's a really good point about the change, especially when we look at pricing right now and supply and demand. I'm assuming that just being able to look at the costs and, the operating budget and the fluidity of that. Let me ask you another question too. We did an interview that was talking about like logistics and specifically around transportation. And they basically said to us, there's no such thing as an annual contract when it comes to the trucking industry. It's going to change immediately. And so in that industry, many people are doing RFPs every 3 or 4 months, and the contract doesn't hold any water because of that changing landscape. Do you see that in pharmacy? Does it have the same level of volatility, or is it a lot more stable and you can get a handle on sort of the profit margins and everything else that come with running a business?
If you're talking about, competing products in the pharmacy market, it is, an RFP of 3 months is pretty generous at the hospital level. Like, they could change tomorrow. They could change next week. Now, there are, longer term relationships for specific medications, specific suppliers that come with some guarantees of supply and things like that. But the focus on controlling pharmacy costs is so great, and the insight overall, right? The view they have is sometimes so limited that, look, the price is $1 or so cheaper a unit. Like, I'm moving there tomorrow, change all the stuff. And we've become really as a result of supply shortages, we've become very agile at moving products, right? Hey, yesterday I could buy as much as I wanted, and today it's all gone. So my downstream impacts have been made very efficient by having to switch products to that end. Now, when folks see a lower price out there and knowing the pressure we're getting from finance, like they're moving quickly. And so
when you look at that price point, there's such downstream effect. Like, you get it, and here it is. It affects so many people within the hospital. How do you get that across? Have you seen really good formed committees that have now moved forward? Then, like, supply chain is always at the table now, but how do you get that internally? Like, when that happens, we're ready to move, but it's not that simple, right? Never happens that quickly.
If we're talking about bringing in like a brand new drug that's new to formulary, that's pretty slow. It needs a lot of approval, especially at academic medical centers. We don't necessarily want to be first unless it's cutting edge technology. We want to see some results. We want to see some more outcomes first. If we're talking about a medication that's already approved, that's been out 20 years, the downstream effects are pretty light. It's a change to maybe a charge number, but there's like I said, again, we've had 15 different vancomycins already this year just trying to stay ahead of the shortage. We're pretty good at that now.
Nice. Appreciate the clarity, because I was going to ask the question, drugs coming to market, has that increased and become quicker because of this world we're in? Is it not an average of 11.8 years? Or are we accepting more from Europe a little quicker? I'm curious just how.
Depends on the disease. Yeah. If it's expensive, it's still slow. So, CAR T takes a year or two to get through. Yep. A lot of these multi-million-dollar drugs take a lot. We're seeing a lot of new approvals. A lot of them are in that biologic space that are very niche utilization and very important, but of course, very, very expensive. Those are they still take a lot of approval. Yeah.
Appreciate that. Thank you.
All right. So as we're kind of wrapping up, the last question I would have is, we really are running the gamut in terms of technology, the access to information and data. The pace of play, as you just described, is speeding up incredibly. So as people look to leverage technology to kind of empower them in this space, what does the future look like and what can be accomplished, especially as you start to integrate into those ERPs, right? Like, can you run a leaner pharmacy supply chain, or do you not really want to lean it out? You just want to accomplish more sophisticated strategies. What can be possible here?
Yeah, I mean, I think really to get pharmacy out of, hey, this drug, that drug specifically, and bring them back to that strategic level and align that strategy with the overall supply chain, there's a lot of potential there if they could get past the firefighting, the day-to-day shortage issues. We really touched on shortages, but, our folks have been so underwater trying to keep the lights on that it's hard to step above. Once you get some space to step above and start looking at your strategy, there are tremendous opportunities out there for hospitals to sort of take charge of their own supply chain, be it drive better contracts, drive better compliance with their different partners, drive better cost of goods with their wholesaler. There's a tremendous opportunity if they can just get above water a little bit and then step back and then align with the rest of the organization and think more strategically about how they buy drugs, where to optimize, where they're going to get the most. We talk to hospitals all the time. They spend a lot of effort in one area that may not have a great return. Just, focusing those resources on the areas with the highest return alone can produce incredible results. And it's not because they don't know, they just don't know where those opportunities are. And so knowing where all the opportunities are in real time, that's pretty powerful for our customers. And then, just going after the biggest one, sort of Pareto principle, and then making sure everything aligns with your overall strategy. So you don't make a change here to save some money, but then you mess up your compliance or another relationship that you had to keep track of. Having all of that kind of in one is really producing incredible results. And so, each year it gets easier with our customers. So
to add on to that, I think really the visibility and accountability cycle shortening has helped a lot. When we look at the future of pharmacy supply chain, being able to know how's my decision going to impact not just my facility, but with hospital M&A 10 facilities. Who's going to be the winner and loser? When something goes wrong, how can I see that faster and react faster? And how can I, predict what's going to go wrong and be able to defend my health system against that? Those kind of things are where we see folks moving forward strategically. It is, but if you're scanning shelf tags, you won't have that kind of insight. And sorry to shelf tag scanners across, I feel for you. I still, I hope you don't feel like I'm disparaging you, but without the right resources, you're not going to make it down that pathway to where the future pharmacy needs to be, where it should have been, frankly, already.
All right, gentlemen, great job with this interview. I definitely hear you loud and clear, Matt, about clinicians being pushed into, roles that are within supply chain that require some real training and some support structures. And I remember working as a nurse. I just saw so many people with no management experience getting promoted into management. And I kind of liken it to a very similar dynamic in healthcare. It's like, this person's really good at this clinical role, so we're going to move them into this other role. And we're not even sure if they have the actual skill set, even though we know they're a great employee. And so how do we give them something that allows them to continue to be a great employee and continue to grow?
Let me say this about pharmacists. You point them at a problem and stick them on it, and they're going to figure it out, and they're going to knock it down, right? These are very driven, very, very smart people. And so when I talk about their background, this isn't to say like that person's somehow less qualified or less capable here, but they just don't have any support. They don't have anything to read from or learn from. And so with this, perspective on training, like how can we get this information across? How can we teach them about contracts? How can we teach them about the tricks of the trade? Again, give them some insight, give them some visibility. It's great to have good examples that pop out, but that infrastructure to get folks trained up in this just doesn't exist.
That was Johnathan Yantis and Matt Hebbard from QuicksortRx, and talking about pharmacy supply chain, Hays. This is the first real focus interview we've done, and we've done several seasons, and I can't believe we haven't had this conversation yet. Pharmacy supply chain is such a big topic, so hopefully this will be the first of many. But just hearing how many pharmacy supply chains even lack basic level technology support structures as ERPs are implementing. If you don't have something today, I just got to think you got to start moving pretty soon, because we know about the talent shortages, and we can clearly see that the pathway here is clinicians being promoted into roles that require them to have supply chain understanding. But as they mentioned, in some cases, no resources from a technology standpoint. We've got to bring this baseline up a level.
Clearly, I mean, and that was interesting to me that, that supply chain pharmacy person is not there. There's not that training typically out there. And so it's obviously a place that needs a lot of help. And obviously they got to implement new technologies to help them do that. And, he even mentioned, big systems, large health systems that are just not doing a great job. And it's not because they don't have the expertise of people, it's resources and those things. So we all certainly need to help the pharmacy supply chain as well. But they brought some really good ideas and kind of just expanded on the problem.
All right, well, that's going to do it for this episode. As a reminder, we'd love it if you downloaded our smartphone app for iPhone or Android, because that's the best way to listen to the Power Supply podcast. But if you're already listening to podcasts on Apple, Amazon, or Google Podcasts, you'll find us there, as well as Stitcher, iHeartRadio, or Spotify. And we love feedback, and we want your feedback around topics. Maybe you've got potential guests. Maybe you listened to an episode and put something into practice that really made a difference. We'd love to share that feedback on one of the shows. So definitely send it our way by email, info@powersupplymedia.net. On behalf of Hays, Garry, and myself, thanks for listening to this episode of Power Supply.